Thank you for the kind introduction and good afternoon to all of you. So for the next 20 minutes or so, we will be discussing the what, why and how of the pre-operative thyroid fitness. So we will be trying to find out the answers of these three questions: the why to optimize pre-operatively, whom to optimize and how to optimize. So the relation between thyroid and heart is known maybe long back since 1786 when Perry described the women with goiter and palpitation. And we know that the thyroid hormones have their action in almost all systems of the body, and it is mediated through thyroid hormone receptors, either alpha or beta. And every day we receive the call from our surgery or gynecology colleagues regarding this type of cases: 48-year-old women having abnormal uterine bleeding, detected to have fibroids, who is known hypothyroid on levothyroxine of 50 microgram and scheduled for a total abdominal hysterectomy with bilateral salpingo-oophorectomy, and now detected to have a TSH of 11 micro international unit per ml and who is TPO positive. So, what are the cardiovascular relation of thyroid dysregulations? And due to the genomic and non-genomic responses of thyroid hormones, it can have effect on cardiac output, peripheral resistance, lipid parameters and consequent coronary health. And dysrhythmias and sudden cardiac death may also be associated with thyroid dysregulation. And hypothyroid patients may have a decreased cardiac output to the tune of 30 to 50%, having increased peripheral resistance. And despite having an adequate catecholamine levels, they may have a decreased adrenergic tone due to downregulation of beta-adrenergic receptor. And because of the low baroreceptor responsiveness, they may have hypotension while being on anesthesia. Regarding coronary artery disease, the relation is through the decreased LDL receptor and hypercholesterolemia, leading to atherosclerosis with the contributing factors like hypertension and of course some impairment in coagulation. However, this hypercholesterolemia is reversible both in overt and subclinical hypothyroidism. Earlier studies have shown that there is an increased risk of post-operative atrial fibrillation in cardiac surgery, those who are subclinical hypothyroidism. However, this recent meta-analysis, which evaluated the clinical outcomes after cardiac surgery in subclinical hypothyroidism, they have found that compared to euthyroid patients, patients with subclinical hypothyroidism had higher rates of operative mortality, prolonged hospital length of stay, and a higher rate of renal complications. However, no significant differences in terms of ICU stay or post-operative atrial fibrillation or use of IABP. So conflicting results are there in terms of post-operative atrial fibrillations in cardiac surgery in hypothyroid individuals. Now, from anesthesia point of view, enlarged tongue, relaxed oropharyngeal tissues, large goiter or obesity may pose difficulty in intubation, and because of the decreased hypoxic and hypercarbic ventilatory drive, the patients may be increasingly sensitive to the sedatives. Impaired respiratory muscle function or impaired surfactant production may lead to increased risk of post-operative atelectasis. And because of glycosaminoglycan deposition and accompanying hypoalbuminemia, effusions are not uncommon. And of course, hematological abnormalities like anemia and thrombocytopenia have been found to be more in patients with hypothyroidism. Other possible complications are acquired von Willebrand disease, hyponatremia due to several reasons like increased ADH or decreased ANF or decrease in RAS activity. Paralytic ileus and gut wall edema are also common. And last but not least, the decompensated hypothyroidism or the life-threatening complications of myxedema coma. So how to approach to a pre-operative patient with hypothyroidism in case of elective surgery? Best to optimize prior to surgery. In adults, we can supplement with levothyroxine at the rate of 1.6 microgram per kg. Except in elderly or those with known coronary artery disease, they should be started with the initially low dose like 25 to 50 microgram daily with a plan to increase every 2 to 4 weeks until a thyroid state is attained. For people aged more than 70 to 80 years, they should be started with a low dose with gradual up titration. For pediatric age group, the doses are usually age-based. And for subclinical hypothyroidism, we usually treat with a lower dose, and if there is as well risk of cardiovascular disease. So, if we look at the studies which have compared the hypothyroid with euthyroid patients, for in mild to moderate hypothyroidism, unlikely to pose any serious adverse outcomes. For non-elective surgery, does not require to be postponed, or it is not necessary to postpone elective surgery in mild to moderate hypothyroidism, because in terms of outcomes of anesthesia or surgery, there is no significant difference. So if you look at the flow chart, those who are known hypothyroid on stable dose of levothyroxine and having a documented report in past 3 months, as well as who are suspected for hypothyroidism and detected to have subclinical hypothyroidism, then they can be proceed for surgery under usual risk. Regarding moderate hypothyroidism, if elective surgery, it is better to replace with the dose we have already discussed, but ideally proceed with surgery once euthyroid. And if urgent surgery is required, then we should start replacement with levothyroxine dose according to the age and presence of cardiac comorbidities. They can proceed for surgery under moderate risk. But people with severe hypothyroidism are always at a very greater perioperative risk. And for elective surgery, always it is preferable to proceed once they are euthyroid and hemodynamically stable. But if an urgent surgery is required, then we need to replace with intravenous levothyroxine, but however it is not available here, and then 50 microgram daily, and may require to give liothyroidine as well. And if we are not aware of, if the hypothalamo-pituitary adrenal axis status is not known, or if the patient is hemodynamically unstable, then we should start glucocorticoid before giving levothyroxine. One important point to note here that patients who require cardiac revascularization are the only subset of patients who may not benefit from pre-operative replacement of thyroid hormone, and for them it is reasonable to proceed with the revascularization procedure before repleting the thyroid hormone. Having said that, the risk of worsening unstable coronary syndrome with thyroid hormone, that is mostly increasing the myocardial oxygen demand, conflicts with the concern that untreated hypothyroidism may worsen heart failure or hypotension in the cardiac surgery patients. So the next part is hyperthyroidism. If you look at the cardiac risks in hyperthyroid patients, there is high prevalence of atrial fibrillation both in overt as well as subclinical hyperthyroidism, and there are factors which can lead to persistence of AF after treatment, like old age, the duration of hyperthyroidism, and duration of pre-treatment atrial fibrillation. Regarding ventricular arrhythmias, the patients with heart failure are at very high risk, and the electrical storm defined as hemodynamically significant VT, if those patients having this underlying etiologies of myocardial ischemia, electrolyte imbalance and other endocrine disorders, they are at very high risk of these ventricular arrhythmias. Regarding heart failure, the causes we know, there are two types of heart failure. There is high cardiac output failure described long back in 1970 that leads to tachycardia-induced cardiomyopathy, and a low cardiac output heart failure mostly seen in elderly in a lesser percentage that increased in patients with hyperthyroidism who are suffering from cardiac disorders like ischemic heart disease, hypertensive heart disease, valvular heart disease with or without atrial fibrillation. Other possible complications are angina, malabsorption, dehydration due to hypothermia, respiratory muscle weakness, hypercarbia due to increased oxygen consumption, hypokalemia, and last but not least, the thyrotoxic crisis. So, regarding the approach to pre-op patients having hyperthyroidism, in case of elective surgeries, prior optimization to be preferred, need to ensure severe safety using the beta blockers in old age, that is who are aged more than 50 years, or those with cardiovascular disease, especially atrial arrhythmias, and may taper after recovery. In case of emergent surgeries in overt hyperthyroidism, we need to decrease level thyroid hormone synthesis as well as to block peripheral conversion, and also you block the sympathetic actions. And prevention of systemic decompensation with adequate nutrition and fluids are also important. So sometimes rapid preparation for surgery is required for thyrotoxic patients, and we may not have sufficient time to render them euthyroid by thianamides before surgery, or maybe thianamides may be contraindicated. So this inpatient regime for rapid correction of thyrotoxicosis may be a week before thyroidectomy, may be followed using beta blocker in this dose, propranolol 60 mg twice daily, that can be continued post-operatively. Dexamethasone 2 mg intravenous 4 times daily, that should be tapered over first 72 hours. In place of dexamethasone, we may use hydrocortisone 100 mg 8 hourly. Cholestyramine 4 mg orally 4 times, that should be stopped immediately after surgery. And saturated solution of potassium iodide 2 drops orally 3 times may be used. No need for continuing post-operatively. In place of SSPI, Lugol may be used. It is having 8 mg of iodide per drop. So if you look at this approach of suspected or diagnosed patients with thyrotoxicosis before surgery, if this is a case of iatrogenic thyrotoxicosis or underlying thyroiditis, or if the condition is considered subclinical hyperthyroidism chemically, then they can proceed with surgery under beta blocker. On the other hand, with overt hyperthyroidism for elective surgery, with use of antithyroid drugs and beta blocker, patient should be rendered euthyroid and hemodynamically stable prior to contemplating surgery. For urgent surgery, it should be in overt hyperthyroidism, they should be managed as impending thyroid storm with antithyroid drugs, iodine, beta blockers and steroids. And they should be taken for surgery under very high risk with an arrangement of ICU. So the key takeaways from this presentation: both hypothyroidism and hyperthyroidism increase risk of adverse cardiovascular events during perioperative period. In case the surgery required is elective optimization of thyroid functions prior to surgery should be preferred. There is, however, no need for delaying surgery in mild to moderate hypothyroidism, because most of the studies have shown that there is no difference in adverse outcomes between untreated moderate hypothyroidism, treated moderate hypothyroidism, and euthyroid individuals. Myxedema, coma, and thyroid storm are potentially fatal complications, and meticulous monitoring in unoptimized cases is indispensable. Patients with overt hyperthyroidism requiring urgent surgery should be treated with multi-modalities including antithyroid drugs, beta blockers or calcium channel blockers, and should receive intravenous fluid for hemodynamic stability. So thank you for your attention.